so that we get going on time here roughly. And thanks for coming to this session, helping realize the vision of zero suffering from the end-of-life TB strategy, for the end-to-end TB strategy by using palliative care. We're going to start our presentations momentarily here. I have some apologies. First of all, my colleague and friend, Dr. Eric Krakauer from Harvard, who has been until recently working as the medical officer for palliative care at WHO, was unable to join us. He's actually on his way to Vietnam, so I'm going to give his presentation. Then Dr. Jenny Hughes will give her presentation. I'll come back to give another presentation, and then it appears that my co-chair, Dr. Viet, is a no-show, so he's not here. So we may end a little bit early, depending on how many, how much dialogue you want to have with us as we give our presentations. But we'll try to make this quick. So to begin with, WHO has actually been promoting the introduction of palliative care, the integration of palliative care into TB care, into the continuum of TB care. And they've taken a number of steps that we'll go through. Dr. Krakauer has no disclosures, and neither do I, for conflicts of interest with this presentation. And these are going to be, essentially 20-minute presentations each. So with this presentation, we're going to discuss the WHO recommendations and the agreements that have been made about palliative care for people with serious chronic illness, which includes TB. That's something we'll talk a little bit more about, because TB is not the typical diagnosis for a palliative care patient, but it does actually fit into the scheme of what we do in terms of caring for those with life-threatening illness. The second objective was to plan ways to integrate palliative care into TB programming to improve patient outcomes, and really importantly to contribute to infection control, and all of that leading toward promotion of universal health coverage. So the strategy, the TB strategy is calling for zero deaths, zero disease, and zero suffering due to tuberculosis. And palliative care is the part that addresses the issue of zero suffering, but also has some impact on the opportunity for a person to be successfully treated. So what happens, most of you, are all of you clinicians, or are you program managers? What's your background? Clinicians, raise your hand. Okay, program managers? Anybody managing programs? Policymakers? Nurses are clinicians. Good, and nursing is probably the most important one in the field. So the kinds of symptoms that are experienced by someone with multi-drug or extreme drug-resistant TB include, of course, some social issues like poverty and stigma and isolation. Physical symptoms, including breathlessness, pain, nausea, and vomiting, and a number of other symptoms we'll talk about when we talk about guideline development. And then considerable emotional distress, anxiety, depression, grief, guilt, and anger. This was an interesting study that I hadn't seen, that Eric noted. It's the DOTS Plus study, just basically looking at the incidence of symptoms among 818 patients with drug-resistant TB. And I was surprised to see nausea and vomiting actually at the top, but it is related to treatment, as well as diarrhea, joint pains, dizziness, headache. Actually, a number of different pains here. The joint pain, the headache, and abdominal pain, but sleep disturbance, dizziness, anorexia. A number of people have studied this, and the symptom burden is quite high for TB in general, but particularly for MDR TB. We all want every patient who gets TB to be cured, and that's true for palliative care. People working in palliative care, we're all trying to achieve the same things. But we know that that doesn't always happen, and we have to be prepared to provide more care so that patients don't have to suffer. What are some of the global agreements on pain control and palliative care that govern WHO's response? Why are they involved here? The first one to talk about is a resolution that we worked very hard to get through the World Health Assembly, which is the governing body of the World Health Organization. That resolution was the first time WHA had actually ever addressed palliative care with a standalone resolution. And resolutions are the things that tell WHO what they're supposed to pay attention to and do. And the palliative care resolution, there was mention of palliative care in previous resolutions on cancer and HIV, but not on one that really spoke just about palliative care. And it's the ethical duty of healthcare professionals to alleviate pain and suffering. This is just language from the resolution. The ethical responsibility of the healthcare system. There's quite a bit of language in the resolution about ensuring access to essential medicines. And so efforts to prevent the diversion of narcotic drugs should not result in inappropriate regulatory barriers to medical access to medicines. There was a lot of call for education in palliative care for all health professionals. A lot of recommendations about policy that's needed for palliative care for member states. There's a whole section on things that the WHO needs to do, like do a better job of monitoring the need for palliative care and the response, which is something our organization has been helping with. I'm the executive director, by the way, I didn't introduce myself, of the Worldwide Hospice Palliative Care Alliance, which is an alliance of all the regional and national palliative care and hospice care associations globally. And we principally do advocacy and helped bring this resolution to the Assembly. But we also do development of palliative care programming in low and middle income countries and quite a bit of communications work. I've been working for over 40 years in palliative care. We started talking about opioid therapy. Most people don't realize that the most effective treatment for breathlessness or shortness of breath is oral morphine in usually initially low doses. But American College of Chest Physicians has stated that this is the case. We had, it was on the Corcoran Collaborative for many years that we effectively used morphine to control that feeling of shortness of breath. It's very effective. And that healthcare professionals should use opioids, particularly in TB, where someone is at the end of life and is having a great deal of respiratory distress. Opioids can be extremely helpful in managing that symptom, not just pain. Back in 1961, all of the countries of the world signed, almost all of them, signed what's called the Single Convention on Narcotic Drugs, which is a sort of treaty that governs how everyone is supposed to ensure that opioids are not misused. And really, about 99% of the focus of this convention has been on, if you will, preventing or controlling access to these medicines, when it is actually supposed to be a 50-50 balance between ensuring no misuse, but also ensuring access for medical and scientific use. And that balance has been off for many years. We're trying to slowly bring it a little more back into balance, but we've got problems like the US opioid epidemic that have been making that difficult. The real problem with access to medicines is not these epidemics that happen in high-income countries, but the fact that 75% of people on our planet can't access an opioid if they need it, if they're in pain. So this balance has to prevent abuse and diversion while ensuring availability. WHO has published Ensuring Balance in National Policy on Controlled Substance back in 2011, calling for this balance to be maintained. Other UN authorities, the Right to Health by the UN Economic and Social Council, ECOSOC, and the US Special Rapporteur on Torture, Cruel, Inhuman, and Degrading Treatment and Punishment has effectively said that governments that don't allow for access to opioids to the people in their countries are in effect committing a kind of indirect torture, or they're guilty of inhumane treatment of their citizens. We also had recently in 2016 a resolution on integrated, people-centered healthcare services. This is actually a pretty big movement within WHO to try to get healthcare systems to be more people-centered instead of health professional-centered, which is usually the case. And really, palliative care is probably your best example of people-centered care services. We can talk a little bit more about that later, but they really are calling for this. By the way, all of these slides are available for you after the conference, so you'll be able to access all the slides we're using today. Eric wanted to just, I think, put in a special plug about alcohol use disorders, which are common among tuberculosis patients, and the fact that we need to be sure that we're treating and helping with that as much as with other symptom burden. Palliative care, I think, one of the main things that is good about palliative care in TB is that we are able to kind of juice up our infection control efforts in the community especially. So it's really important that this is a brand new paper actually in New England Journal on the lack of infection control and the need for palliative care in the community. So what would an integrated, people-centered health service for people with drug-resistant TB look like? Really, like other palliative care, we're focused on the community. A lot of TB care occurs in inpatient settings, but I think one of the things that we bring to the table is a more robust capacity to deliver home-based care services to people. And to do that in a way that is ensuring that the community is protected by ensuring good infection control practices. Providing symptom relief, I think, many times can make it easier to stay on treatment and not have the side effects of treatment that may cause someone to become extensively drug resistant. So how do we integrate palliative care in? This is the WHO definition of palliative care, which has been around since the 90s. This was revised in 2002. Palliative care improves the quality of life of patients and families facing the problems associated with life-threatening illness through prevention and relief of suffering. It's not just relieving suffering, it's knowing what to look out for, what's going to come down the line, and being able to effectively prevent pain and other symptoms from occurring. Using very in-depth, we call it impeccable assessment and treatment of pain and other symptoms, but really holistic care, the whole person care, physical, psychosocial, and spiritual. We have seen not that much progress in terms of integration of palliative care into national TB programs. The 2012 report from WHO identified 9 European countries and South Africa as having integrated palliative care. And then by 2013, only 11, 10 in Europe and South Africa had effectively integrated it into the national TB program. So every country that has significant impact, that's impacted significantly by drug-resistant TB should have palliative care as part of their strategy. We all know the companion handbook. We've had palliative care now in the last 2 editions. We had a little chapter on palliative care in 2014. We've done a revision and expanded that section on palliative care in the handbook that's not yet out, but will soon be released with some practical guidance for symptom management. A lot of times when we think about palliative care, we think of it, it's that specialty. Well, we really have been working to try, and the effort of the resolution was to integrate palliative care into existing healthcare systems. So what we need to do more is train direct care workers, healthcare workers of all kinds, including community health workers, on palliative care so they can use a palliative approach throughout the illness. And then if the person is experiencing particularly difficult symptoms, then we can use specialist palliative care services as needed. The majority of patients don't really actually need specialized services. So WHO has a public health strategy for palliative care and also for developing a national palliative care program by starting with a situation analysis or needs assessment, ensuring that palliative care is included in policy guidelines, essential medicine accessibility, and especially a lot of countries have injectable morphine, but it's not effective in managing pain and other symptoms. We really need oral morphine, tablets or liquids, in order to effectively do that. And it's still a big problem around the world. And also, people are afraid of using morphine. It's really one of the safest drugs we have once we teach people how to use it effectively and assess pain properly. Education is needed for the public as well as clinicians and all health officials. And this is the kind of a model that we use, which is policy on top. Is this working? No. We always put the patient and family in the center. We need, at the same time, education and medicine availability. If you have just medicine and no education, then no one uses the medicine. If you have education, but the clinicians don't have access to the medicines, they never really learn how to use them effectively and don't use them. All of that leading to implementation. But it's a fairly simple model, but we've used it around the world really to build palliative care at the country level quite effectively. And there's a whole lot of detail underneath each of these. There's a whole long list of the policies needed. Of course, WHO's essential list of medicines includes a section now on pain control and palliative care. And then we have lots and lots of curriculum. We even have a special curriculum for teaching palliative care for TB patients. One of the things that makes it attractive to do palliative care, and one of the things that why WHO has encouraged countries to develop palliative care and improve palliative care, is that we actually have found the evidence is strongest in high-income countries, but we found very good evidence that palliative care reduces unnecessary hospitalization and emergency room use and other high expensive costs of the healthcare system by providing more appropriate care. Again, preventing unnecessary hospitalizations is the key. There's a couple of studies here that are referenced. There's actually 40 or 50 studies, including a couple of recent reviews that have been done that are quite clear about this, though we do need more evidence in low and middle income country setting. So for a TB hospital, the kinds of services should include having an interdisciplinary team that includes physicians, nurses, social workers, and chaplains, psychologists also sometimes, inpatient beds for patients whose symptoms are severe enough that they need to be in an inpatient setting and their symptoms can't be managed at home. At least these are usually short-term admissions for symptom management because we're quite good at getting the symptoms managed pretty quickly. Having a consultation service so that people can see a patient in different parts of the hospital when called on to do a consult and make recommendations about whether palliative care is needed at that time. And then availability of outpatient services. And of course, many clinics. Most countries have multiple clinics. And most importantly, having the capacity not just to make occasional home visits, but to have an organized program of home-based care that is conducted on a continuous basis that ensures that the patient and family are being cared for, and referral between settings. Community health workers, especially in low and middle income countries, are the key to making this all work. It will not work, however, if they are not backed up by well-trained medical professionals, physicians, nurses, other mental health professionals. Community health workers, this model actually emerged out of India originally, and it's extremely effective in delivering care to people in their own homes. But the key is that there has to be an interdisciplinary team that is supporting the community health workers. So when should palliative care be provided for drug-resistant TB? And as this definition, the WHO definition says that palliative care should start from the point of diagnosis. In this case, we're talking about drug-resistant TB, but I think there are other special cases or difficult patients with extra, with symptoms of TB, with problems with TB that palliative care can be helpful for, even if it isn't actually crossed into drug-resistant territory. So there really isn't a contradiction between curative and palliative care. That's something that is unique to the United States, that there's a limitation on access to hospice care if you can't get curative treatment, though curative treatment in cancer and some other diseases is a sort of iffy proposition. But certainly we want everyone who has TB to get appropriate TB treatment until they reach a point where a decision is made to discontinue treatment. It can promote adherence, reduce morbidity, and particularly mortality. But when curative therapy isn't effective, feasible, or appropriate, instead of saying there's nothing more we can do, we're able to actually say, well, we can actually provide palliative care and ensure that your comfort is maintained, and that your family will be given the support they need and be supported after the death in bereavement. Finally, just some comments from Dr. Krakauer on ethics of tuberculosis. The medical ethical principles important, most of you are probably already familiar with: social justice, the duty to treat, the duty to adhere to and complete treatment, to protect public health, to support patient autonomy and agency, having informed consent, ensuring confidentiality, not harming the person and not abandoning the person, importantly. So in going forward, we know that there's evidence for cost effectiveness of palliative care. We know that community-based care with community health workers connected to clinicians can help, can be done, can save money, can reduce transmission, can improve adherence, can reduce unnecessary hospitalization, can improve outcomes, and quality of life. So we are asking this, we're saying that people, all TB clinicians should have at least a basic training in palliative care. And by all means, TB physicians should have the ability to prescribe strong analgesics like morphine. And with that, I am going to turn over the podium to our next speaker, Dr. Jenny Hughes from South Africa.
I've been working for MSF over the past 7 years in the MSF project in Khayelitsha, which is in Cape Town, for those of you who haven't been there. I'm presenting on behalf of Lee Sneeman, who is a nurse, and she is responsible for teaching me all about palliative care in our work with drug-resistant TB patients in Khayelitsha. So sorry that she can't be here today, but hopefully I'll do this justice for her. So I just wanted to give a quick anecdote. I just thought about it this morning. Just before Lee arrived in our project to sort of provide a lot of the patient support aspect to our project there in Khayelitsha, we had a patient who I think sums up how much we need a palliative care approach to patients with drug-resistant TB. So this patient had been diagnosed with MDR-TB, had started treatment in the primary healthcare clinic in her community, had a really rocky course. Her journey wasn't great because she had defaulted treatment for various social reasons. But in the end, the MDR treatment over 2 years had not worked, and the clinic staff had told her that treatment was probably going to be withdrawn because it wasn't working anymore. So she sort of defaulted, I suppose, but basically she realized that was it, and she sort of got lost, and we couldn't find her again. As it turns out, she was still living with her many family members in her shack in Khayelitsha and probably infecting a lot of other people along the way, but not getting any support from us. Eventually, she got so sick that she came to the clinic in desperation, and the nurses refused to see her because they said, well, firstly, you're a delinquent patient because you ran away and defaulted, and secondly, we don't want an XDR treatment failure patient here because we don't know what to do with you. They called the MSF counsellors, and we kind of started getting involved, and we went and met the patient at the clinic, arranged for MSF transport to take her to what used to be what at that point was our inpatient facility. It's now been handed over from us. And we called the parents and told them to meet us at the facility. And when we got there, she arrived in the MSF transport and promptly hemoptysized and died immediately. So the last hours of her life were really distressing in that she was completely stigmatized and ostracized by the very people who should have been helping her, and must have been really scared without the support of any family or any relief, any medical relief. So that's really when we started focusing on the palliative aspect of patients in Kalycha. We're fortunate enough to be able to access lots of new drugs like bedaquiline, delamanid, etc. And yet still we do have XDR patients or patients where treatment is failing who require palliative input from our side. So I'm very thankful to Lee and the patient support team for teaching the rest of us what palliative care is about in drug-resistant TB. So I'm not going to go over this again. Stephen's already mentioned the WHO definition of palliative care. But this is, I guess, the way I used to see it, and I guess lots of doctors do, and well, lots of clinicians might, where you have a patient who's diagnosed, they start their treatment with curative therapy or life-prolonging therapy, and it's only really when they reach the terminal phase that you think, okay, there's nothing else left, got no medicine to give you, now we need to get the palliative people involved. So it's kind of this view that palliative care is only needed when curative care has ended. In some areas, there's a bit more of a progression where you see it's slightly more integrated, and palliative care maybe is needed, towards the end of life-prolonging therapy when it looks like it's failing and you want to start getting people involved a little bit earlier. But essentially what we would like to see is that palliative management, as Stephen mentioned, is completely combined with curative or life-prolonging therapy, and that they're implemented together and provided throughout the course of disease. I mean, after all, if you're diagnosed with MDR-TB in a place like Kalycha, you have a 50% treatment success rate. So right from the outset, from your diagnosis, there is half a chance that you're not going to make it through this treatment. So really, the earlier we get palliative care involved, the better. So I'm just going to give, most of my talk will be about this case example and just trying to explain how this is a good example, we feel, of how we think that this patient was managed very well through his journey, bringing into play all of those aspects of palliative care. So this patient was a 27-year-old man, transgender man, which is not uncommon in Kalycha, but is not very commonly admitted or acknowledged, and so it can be very stigmatizing in itself. So you can imagine the level of social support he might have had to start with. He was HIV negative, repeatedly tested, unemployed, was living alone, didn't have any child contacts, and he had previously had an episode of drug-sensitive TB, and he was cured. So in March 2015, he presented to his clinic with new TB symptoms. He was quite stable, ambulant, but his gene expert showed he had RIF-resistant TB. So the culture confirmed it was just MDR-TB. I say just, it was MDR-TB with susceptibility to the second-line drugs. So in April, he commenced his standard MDR treatment regimen, and then at month 3, all the sputum cultures had been contaminated, so we couldn't say culture converted, but then interrupted treatment for 6 weeks, mainly just because, the reasons he gave was just that he couldn't really be bothered to come to the clinic, he had better things to do, etc. So a little bit of interruption there. But then in August, he returned to the clinic, said he was coughing again, but his weight had actually increased, and he was fairly stable. His August sputum culture then came negative, which was great, and he resumed his MDR treatment with the injectable. At month 8, he had culture reversion, so back to positive again. He was losing weight. He really didn't like the injection. As I'm sure you know, many patients get big abscesses because they don't have a lot of muscle mass. This patient didn't weigh very much. And at that point, because he'd had 8 months of treatment with the standard MDR treatment regimen, he was considered MDR treatment failure. So we offered him a strengthened regimen with everything we had available at the time, which was bedaquiline, linezolid, clofazimine, along with fluoroquinolones, PZA, and some of the other second-line drugs. So then in January 2016, he started on his new regimen. And at that point, the sputum taken then showed that he'd actually now had additional resistance to the injectable as well. So he continued on that regimen with bedaquiline. After 6 months, he still had not culture converted, lots of contamination. Weight hadn't gained, he had bilateral extensive disease. His adherence hadn't been bad, but we withdrew the bedaquiline because he'd finished 6 months and the treatment was failing. He was considered then to have pre-XDR treatment failure. So by August 2016, last year, he'd had treatment for 15 months in total. He'd stopped the bedaquiline but continued the rest of treatment. Not eligible for surgery because it was bilateral disease. The NICS trial wouldn't take him because he'd had exposure to linezolid bedaquiline. And we have a national committee for new drugs. We presented his case there, and we presented to the provincial sort of legal review board for some kind of agreement on the way forward. And everybody agreed that really this is a case of, just needed to withdraw treatment and manage palliatively. But this patient was desperate at this point. I think it really sunk in, and he begged to continue. Now, it's really hard when you've got the kind of experts behind you saying this is what you should do, but you've got the patient in front of you saying, please, whatever you do, don't stop this treatment. I really think it's going to work. So I personally didn't think he would have long to go, so I thought, what harm can it do? Let's just continue to give him the treatment. I'm sure he won't last long. That point, we really started sort of upping the palliative support. And we commenced the palliative pathway with symptom assessment, psychosocial support. So November 2016, 18 months in total now. He'd much improved. Lee, actually, thankfully, had suggested we start him on mist morphine. He suddenly was like, Doc, I feel so much better. So that he was just feeling better from not having so much shortness of breath. And we were really worried that he would think that morphine was an anti-TB drug. So there was a lot of counselling involved. And he actually culture converted again. January 2017, so beginning of this year, still on morphine, but his cultures had converted, but he really wasn't improving. So I wasn't happy with the regimen as it was, and I thought if we're going to continue regimen, given that he's survived this far, we really need to give him the best that was available. And we had started getting access to delaminid. Therefore, we applied for delaminid and meropenem, and we restarted bedaquiline based on an extended DST result, along with his regimen that he was taking. So by March of 2017, he was admitted to hospital for close monitoring because he was on meropenem. He had an IV port inserted and started the regimen. He was really hopeful. From March to June, so 4 months on this salvage regimen, his shortness of breath increased, his weight loss went on, he increased his morphine requirements to 4 times a day, hadn't culture converted. He had skin breakdown at the IV port site. It just wasn't healing. It wasn't infected, but it just wasn't healing, so it was removed and meropenem was stopped. But the thing is, this patient was he was so desperate for treatment. I mean, it was really heartbreaking. He would just sit in front of you, hardly able to breathe, and say, no, I'm really fine, I really think I'm getting better. And all the signs were telling us he wasn't, but he refused to acknowledge to us that he wasn't getting better because he knew there was nothing else. Eventually, we transferred him back to Kailicha, where we haven't. So this is another point I wanted to make, is that we had this inpatient facility in Kailicha, which would accept palliative cases. Now, that is the only facility. It had 2 palliative beds. It's the only facility in the whole of Cape Town, and to my knowledge, probably one of the very few across the whole of South Africa, that would accept palliative TB patients. There's no palliative facility in Cape Town which will accept any TB patients. So even though South Africa technically have adopted of integrated palliative care standards into the national treatment program, we can't provide palliative facilities for DRTB patients. So luckily we had this bed in Kailicha, so we transferred him back there. And it was probably only about less than a month that he survived. So he died very shortly after transferring him back. But in that time, I really think that his quality of life was as good as it could have been. We got his family to become involved. They came, they rallied around him, even though they hadn't been involved previously, they'd refused. He really took a lot of comfort from that. He had some spiritual support from a pastor who came in. He had privacy in his own room. He had the dignity of being able to decide if he wanted to continue his treatment or not. We gave him all the information we have. We didn't keep anything from him. He asked me very pointedly, am I going to die? And I just said, I think so. I can't say for definite, but I think so. It looks that way. And immediately after I told him that, that was the day he died, and he really just relaxed, and we had really good symptom management with a lot of support from Lee, who has a palliative background. So just in terms of the timeline, from March 2015 to August 2016, when we were proposing treatment withdrawal, you could see that as his curative management phase. And within that time, we had symptom management, there was a lot of education and counselling, so our patient support team was very strong in Kailicha at the time and providing a lot of education to the patient. We were centering our care around the patient, respecting his wishes to continue treatment, trying to make things work for him in his situation. We were building trust between him and us and providing a continuity of care right from the beginning, right through to the end. And then once we were looking at treatment withdrawal, our counsellors are trained in breaking bad news and dealing with the patient in denial. We dealt with a lot of the symptoms through medication, through helping him with the missed morphine. We made arrangements to collect his medication at the clinic and bring it to his house because he couldn't walk around very well. Made sure the infection control measures were okay in case any of his friends came to visit. And then Lee has put together this emergency action plan. So for a patient who is potentially going to have a massive hemoptysis or whatever, she provides a bucket with towels and sort of practical tools that they can use if they get into trouble. What their plan would be if they did suddenly become short of breath, who to contact and where to go, and then a letter for the hospital staff so that they don't just do a gene expert and start him on MDR treatment on arrival. And then, that next phase on the salvage regimen was all about sort of the symptom assessment and management with a small, another section of curative management when we tried the salvage regimen, but then that end-of-life care pathway kicking in right at the end. We often look at patients where treatment has failed and say, oh, this patient has failed treatment. But really, we try and look at it the other way around, that a lot of things have been failing the patient and not that the patient was bad. So the treatment was failing him. He was potentially receiving a suboptimal regimen. The hope of the healthcare workers in the fact that his treatment might not work, that was failing him as well. His body was failing him. He was having these symptoms which were hugely debilitating and meant that he couldn't carry on with his everyday life. His friends and family had been failing him by all the stigma surrounding TB, surrounding his transgender status in this very traditional society of Xhosa people. He was living alone. He had very little family support. And the healthcare system was failing him. We have there seems to be this unwritten rule in Kailicha that if treatment is withdrawn for TB, then you can't go anywhere and get any treatment. So we try and encourage patients to say, look, you can still go to your primary care clinic for pain control or an ear infection or whatever problem you might have, or to take your ARVs. Just because your TB treatment has been withdrawn doesn't mean that we've all given up hope. So in terms of the patient support team's input to relieve the suffering in this man, we agreed to continue TB medicines on the patient's request. We were encouraging hope by making sure that the patient had insight into the situation, but not false hope, just a realistic view of the situation. We were assessing and treating his body. We were educating his friends and family as far as possible. And we were supporting the existing healthcare system to allow him to access necessary medication, to get extended DSTs done when we were looking for a salvage regimen, to access respite care and emergency admission had he needed it. Now, I just want to point out at this point that MSF and Lee specifically has developed a very comprehensive counselling guide for DRTB counsellors, so lay counsellors, and it goes all the way through from diagnosis through all sorts of situations for XDR patients, MDR patients, and it includes a toolkit and includes a section on palliative care as well. So go onto the MSF website to look up that toolkit. It was published a few years ago. And then just to mention the ethical issues in this case were around the patient autonomy versus, what us as the doctors felt was our responsibility to the patient and to the community versus the patient review board, this legal board that decided to withdraw treatment. So when does the patient get to choose the public harm, so there was an infection control implication of this patient staying in his community, but we reduced that as far as possible by making sure that he had everything he needed within his home, and so reducing the risk to others. And then limiting the access. He had limited access to information initially, but then we were able to share with him and educate him on alternative options, and he could make the choice as to what he wanted to do. So I think this case emphasizes that there are lots of challenges associated with living with a life-threatening disease such as XDR-TB, and the challenges are multifactorial and complex. Relief of suffering isn't just at the end, it's at multiple levels of care through the patient's journey. We need earlier implementation of palliative care because it makes all the difference to the patient, and it's often not implemented early enough, if at all. And palliative care provision requires training, so we need to be training our healthcare workers. So this is my last slide. It was just some recommendations that were put forward that although the South African RIF-resistant TB palliative care guidelines have been drafted in 2016, they have yet to be finalized or implemented, and that should really be prioritized. Healthcare workers need routine palliative care training, and that should be prioritized at a provincial level and also a national level. We really found that there was a need to strengthen partnerships between palliative care organizations and people working in that sort of field and the primary and secondary care facilities who are looking after the DRTB patients predominantly. So resources such as morphine availability, dedicated facilities for palliative care, plus partnerships with other organizations, plus training, plus early implementation of palliative care equals hope for an improved quality of life for XDR patients. And that is it. I'm happy to take any questions. Any questions? Yeah. Oh, it's that. Yeah, absolutely. No, great, thanks. I'm glad you asked. So Lee works for MSF as a nurse. She doesn't provide direct patient care, so our role as MSF is to support staff within the facilities. So really what she's brought in is, from her background of palliative care training, she's sort of engaged with individual facilities and the nurses there. So when a palliative patient or an XDR treatment failure patient is recognized, she sort of goes specifically to that facility. So it's not sort of wider training on a routine basis that she does, but it's very much just one-on-one mentoring with the facility staff. And she does a lot of, she starts off with a lot of values clarification, so what are people's opinions about XDR patients? It's amazing how many healthcare workers will see XDR treatment failure patients as these bad delinquent patients who deserve what they got, So really breaking down those kind of barriers and then using the counseling team. So often the counseling team are people who have had MDR-TB previously and who have been cured and are now working as counselors. So they have a very good communication with the patient, but also they probably have better communication with the nurses there because they speak the same language, they're from the same culture. Lee is not closer. So, really sort of building those links and then trying to train them that way. Her role as well in encouraging doctors, it takes a little bit of courage sometimes, I think, for a nurse to come to a doctor and say, you need to prescribe morphine, because the doctor will be like, I know better. But she really, just the way she does it is very good. And she has been encouraging doctors and just using these cases to say, look, this could really help this patient. And I think for this patient, I think everybody saw what an amazing impact it had. So I think that's just, helped with future cases. So a lot of training, a lot of one-on-one sort of working with people in the facilities, yeah.
I work in the U.S. as an MDR nurse coordinator and have become really interested in and done some training in palliative care. And as I've seen from experience with family members and stuff, that it is often accessed late, and that there could be benefits earlier in treatment. And I'm wondering what you think, or if anyone has experience providing that supportive care, even for patients whose outcome might be positive, but they're just really struggling, and sometimes they've reached an impasse with staff who get frustrated. So I'm just curious what you think about providing it earlier and the practicalities of that.
Yeah, so I think, talking about sort of palliative care and then curative care, you just want to talk about one sort of pathway, really. Yeah, but essentially I think we really undervalue the importance of sort of counselling and patient support, So Lee in our setting leads a team of lay workers, as I said, or counsellors who meet people right from the beginning. So they get counselling, 3 counselling sessions, every MDR patient gets that. But as soon as they get an XDR diagnosis, then they get an additional counselling session, and that really starts the palliative process. So in her counselling toolkit, she sort of starts broaching things like, oh gosh, you have this very life-threatening illness, we're going to do the best that we can for you, we've got all these new drugs which we're going to try, but if it were to happen that things didn't go the way they should, then what would you do in your situation? So they tailor it very much to the individual. So how would your child still go to school, and do you have money set aside for a funeral plan, which a lot of people worry about in Kailicha, and who would be the people that you would have to get involved, and maybe you should just start talking to them now. So she really gets involved more with the family, and they do a home visit as well. So I think just having that initial counselling session helps, because then when you get to them later on down the line, you can sort of say, oh, remember we talked about this previously, and have you done anything towards that? So so I think the counselling and the patient support side of things is probably more important. I mean, the doctor doesn't always have time to go into that as much as they'd want to. I don't want to paint the doctors as a terrible picture, because a lot of them really have that compassion, but they just don't have time to say it. So having somebody else who can do that is great. But yeah, I think right from the beginning is essential.
Well, thank you very much for your presentation. Well done. And I'd highly recommend it if you're interested to download it from their website. It's very practical, really well done. And speaking of guidelines, this presentation is going to be about the development of the guidelines that were mentioned for South Africa, which are at the present probably the best quality clinical guidelines we have for palliative care for TB. And it is a bit frustrating that the slow process of having these guidelines reviewed. I led the development of the guideline group that developed the guidelines, so we put a lot of effort into it, a whole lot of people's time, and we'll talk a little bit about what's in them, give you some thoughts, let you know where you can download them, etc. So this is about our experience in both Kyrgyzstan and South Africa with guideline development. First, it's always, I just want to say again that palliative care people want TB to be cured. It isn't, our objective is not that people don't get treatment or get cured, it's that they get cured. But we can't always cure the patients that we see. So in our little planet, we have about 1 million people a week who die. It's around 56, 57 million total deaths. And actually today, a new report has just been released by the Lancet Commission. We had estimated that a minimum of 20 million people at the end of life needed palliative care with WHO. Lancet Commission has increased that to 25.5 million. And we said around 40 million total when you count people who need palliative care before the end of life. And they have estimated by using some sophisticated methods of measuring serious health-related suffering. That number now is 61 million. So the need is quite large. And of course, always in palliative care, we take care of both the person affected and their family. So usually you can add 2 or 3 family members or so into that, and you get well above 100 million people a year. The 2015 data have 1.8 million TB deaths. In spite of improvements in treatment, new meds, better outcomes, we're still seeing large numbers of people dying. That includes 400,000 co-infected with HIV and 480,000 new drug-resistant cases globally. We do put the patient and family at the center. This is the patient and family in the center, surrounded by the interdisciplinary team, surrounded by the community. It's the kind of model we use in terms of interdisciplinary palliative care, rather than being a hierarchical structure where the physicians are basically ordering everything and people are following orders. We do, as Jenny said, we carefully look at the values the person has. We look at their goals for care. What is it they want? What's important to them right now, whatever point they are in their illness? And we build the whole care plan around their goals, not ours. We mentioned that we had, with WHO, published a global atlas of palliative care at the end of life, which gave us some numbers. This was the very first time when we had WHO was able to publish something that said that drug-resistant tuberculosis is one of the diagnoses for palliative care. It's just a little under 1% out of the roughly 20 million people that we estimated at that time needed palliative care. But prior to this, I mean, basically the only thing that you saw from WHO was, well, yeah, you need palliative care if you have cancer, yeah, HIV, okay. But they didn't say much about cardiovascular disease or chronic obstructive pulmonary disease or other conditions people need palliative care for. But we fortunately forged a partnership with Dr. Ernesto Jaramillo. We had a conclave back in 2012 where we brought together a lot of the TB experts and the palliative care experts, and we wrote a declaration on palliative care for TB, and that began a partnership that has resulted in WHO actually taking some leadership on this. This is a little bit older map now of the rates of mortality for tuberculosis and for including HIV positive globally, and of course red is the hottest and green is the least incidence, least mortality. And we know that about 80% of the need for palliative care is in low and middle income countries. Unfortunately, we have a kind of 80-20 problem, which is that 80% of the care, palliative care services, are in high income countries, and less than 20% are in low and middle income countries where 80% of the need is. This year, tomorrow, is World Hospice and Palliative Care Day. And our focus this year is on universal health coverage. And we said, universal health coverage in palliative care, don't leave those that are suffering behind. So if you get a chance tomorrow to celebrate with us, we'd be happy if you did. That's always the second Saturday in October each year. These were some of the publications that resulted from the partnership between WHO and the palliative care community. We published in the Tuberculosis International Journal, the union's journal, the declaration. We took some interesting flack for that. We had some letters to the editor saying, this is unethical. We can't provide palliative care to people with TB. And it was great because it gave us a perfect segue into being able to directly educate people about palliative care and its importance in TB care. Because of the myths and the false assumptions people have about palliative care being somehow in place of TB care, which it certainly isn't. And we published it in Lancet Infectious Disease, also just to strike that point. I spoke about this, or actually in Eric's presentation, the World Health Assembly resolution on palliative care, which has been a watershed for us. And of course, the Global TB Program's vision of a world free of TB. And I think we can thank Ernesto Jaramillo for getting that third circle in that ring, in those rings of zero suffering. So back in 2012, we had some funding to be able to develop some clinical guidelines for Kyrgyzstan one of the more affected countries for tuberculosis, and developed a set of guidelines that were, a lot of which came from South Africa originally, actually, and were adapted for Kyrgyzstan. And we took those guidelines and then developed these comprehensive guidelines for TB and drug-resistant TB for palliative care and support in South Africa. And these are the guidelines that Jenny was referring to that are really at this point kind of the state of the art in terms of guidelines on palliative care that are specific to tuberculosis. And you'll notice we said, TB and DRTB in the title, because there were some TB non-resistant or drug-sensitive patients who needed palliative care as well. These guidelines rely heavily on the Hospice and Palliative Care Association of South Africa's clinical guidelines, which are comprehensive clinical guidelines for palliative care. We started off by first saying, okay, well, what are the domains of care that we need to include in a clinical guideline? And these are the 8 consensus-driven domains, if you will, of palliative care: structure and process of care, physical aspects, psychological, social aspects, religious, spiritual, and existential aspects, cultural aspects, care at the end of life, and ethical and legal aspects. And there has been a consensus around this sort of domain structure globally for a good while now. These were originally published in the US, but they've been used, I think, throughout the world quite a bit. We addressed some difficult questions that come up, like the first being, why is tuberculosis unique for palliative care? And there aren't too many conditions on that list of diagnoses that are treatable and curable. There's only a few. But when you think about it, I mean, it's not that different than cancer. You know, we treat people who have cancers, who have metastatic cancers, and sometimes they recover and sometimes they don't. So the drugs sometimes fail people, and that's the case in TB as it is in oncology. But there is an expectation of cure with TB that we don't quite have with cancer. We kind of, when someone gets a cancer diagnosis, we think, immediately start thinking they're going to die, where with TB, we want them to, the expectation is that they're going to live. Jenny and I think I have talked about which patients should be receiving palliative care and when, and I think we want to try to integrate it into the whole TB care system so that the approaches are used from diagnosis forward, and then we can juice up, if you will, or increase those services as treatment is either phased out or slowed down or discontinued entirely. And that structure we've talked about in Eric's presentation a bit about which kinds of services in the hospitals and the outpatient clinics and in the home-based care, and with a focus on putting much more resources and emphasis in home-based care in order for this to work. What the essential medicines are, and particularly ensuring that people living with TB have access to morphine when needed. How do we train staff? What are the curriculum? We do have a curriculum. And how do we also educate family? So these were all topics within the South African guidelines. The transition to palliative care services. This has been a difficult process. We discovered as we were developing these guidelines that there really was a lack of clarity within the TB treatment community about how you go about doing this. I mean, Jenny's case was a great, I think almost a perfect case example of how you do this well. You don't force it on the person. You let them come to the point of realizing that, that it's time to shift the goals of care toward comfort and quality of life. But how you go through that transition and do it in an ethical way is very tricky and not easy. That's true for, I think, people with many other diagnoses, but it's especially true, I think, with TB. How you develop a care plan, an interdisciplinary team plan of care, and how do you care for the family. These are all topics within these guidelines. We don't have time to go into the micro detail about each of those, but I would encourage you, if you're interested, to download a copy from our website and check and review them yourself. The clinical aspects of palliative care. So it isn't, guidelines are not just the clinical aspects of care. It's also about, when they're comprehensive, it's about how you go through and answer and deal with these particular issues. But we focused in these guidelines on cough, shortness of breath, hemoptysis, fatigue, sweats, pain. Those were the physical symptoms that got most attention. Psychological and psychiatric care focus on the common experience of anxiety and depression. How to do effective communication and break bad news. Those are topics that we typically just teach everyone in palliative care. But I think NSF has done a particularly good job of developing training materials for that, for those, and then the social aspects of care. And some people have said that dying is not a medical event; it's a spiritual experience or a human experience. And I think we have to pay a lot of attention to religious, spiritual, existential, and cultural aspects, including how do we assess people's spiritual needs, and how do we intervene, and what are spiritual interventions? What are the particular concerns about taking care of someone with TB at the end of life? When death is approaching, how is infection control managed? We frequently use the buckets, if you will, with the red towels to reduce the sort of visual trauma of someone bleeding out. Then the ethical and legal aspects of care, rights, treatment decisions. Isolation and detention has come up and is becoming a concern. Getting your affairs in order, and then advanced care planning, all of which were covered well, I think, in Jenny's case example. So how do we move from a specialized service? I mean, right now, palliative care is primarily a specialized service, not just in TB care, but in healthcare in general. And really, we're in a transition to community-based primary care model of palliative care. And how do we get there? That's something also addressed in this. We have developed a 5-day course for TB professionals. It has 27 modules. We actually replicated, we did the training initially in Salzburg, and then replicated it in Bishkek in Kyrgyzstan. And it's available, the curriculum is available for use if someone needs access to it. It was funded by Open Society Foundations, and it's pretty comprehensive, developed by both palliative and TB care professionals. And it's on our website to download. This is actually and again, you'll have access to these slides afterwards, but this is the link to where you can download the South African guidelines at present, even though they're not officially published by the Ministry of Health. They were approved, but they were sent out to the provinces for feedback, and we've been waiting now for more than a year, I think, in terms of getting feedback and finalizing them. So on that note, I want to thank you very much for your kind attention. We have time, lots of time, about a half hour, little 25 minutes, for discussion, questions. Maybe you can share with us a little bit about your experiences and why you came today and what some of the challenges are you're facing. There in the back, let me come to you with the mic. We're recording everybody into the audio presentation of this session, so please use the mic.
Thank you. So my main area of research is actually ethics. So I want to thank you both for highlighting the importance of ethics in palliative care. I think that's tremendous. So one thing I want to note is actually the WHO just published this past year its updated ethics guidance document for tuberculosis, and there's a chapter dedicated to palliative care. So if you're interested, please take a look. But a lot of the issues that, and Nista's one of the key editors, so a lot of the issues that you brought up are in there. I want to just ask you and Jennifer a question with regards to global support for palliative care. So to what extent do high-income countries assist those low-income countries with regards to the resources necessary for palliative care? So you mentioned the 80-20 divide. And what conversations there have been, if there have been conversations about that?
Great question. unfortunately, there's very little support from high-income countries for low- and middle-income country palliative care development. There was, when the PEPFAR program was put into place in Africa, there was a requirement that palliative care be included and covered. And so a lot of support for people with HIV came through that, but unfortunately the government, our government, the US government, defined palliative care as pretty much everything that anyone did to anyone. So it was very much watered down. The joke was it's everything but bed nets. And, you know, of course TB was, people living with HIV and TB, you know, co-infected, got some support, but that money has not continued. We're doing a project in Bangladesh funded by DFID to develop palliative care in the slum communities there that'll include some TB patients, but it'll be for everybody. But almost all the trilateral or bilateral agencies of government in high-income countries have no support for palliative care, almost no support. European Commission has done some projects, but they're sort of spotty. We also, you know, have no support from some of the bigger foundations, like Gates Foundation is allergic to palliative care. They only want to cure disease. And they've made that very bluntly clear to us over the past several years. I think, unfortunately, Bill Gates Sr. may have to need palliative care before Bill gets religion on palliative care. But no, it's very disappointing, and I think it's a problem. We had a report last year at the World Health Assembly on the 2 years following the 2014 resolution on palliative care. They pretty much just glossed over it. They wrote a one-page report that didn't say anything meaningful. We're mounting an effort at present to try to get it back on the World Health Assembly agenda and to seriously look at why there isn't, why do you pass a resolution at the World Health Assembly and then not support it? Which is not a unique thing at WHO. It's happened before. But there is support at WHO for palliative care. It's in 2 clusters, in the health systems cluster and in non-communicable disease and mental health. But it is a cross-cutting issue. It's not a cluster issue. It's really, it actually would, almost every cluster, if you will, at WHO is affected. One of the good things is that Dr. Tedros is a big fan of universal health coverage, and we were successful in getting palliative care included as one of the elements that are used to describe the continuum of universal health coverage. So, prevention, promotion, treatment, rehabilitation, palliation, that is the continuum of universal health coverage officially at WHO. Disappointing, though, in terms of resources. There was no money given by any member state to support palliative care implementation at WHO. 0. Which we've been complaining about as loud as we could.
Thank you for interesting presentation and interesting session. Can you provide a little bit more information about infection control in the places of residence of such patients? Because they stay infectious for many months or even years, and they spread the most dangerous form of TB, XDR TB. And the second question, have you registered active TB cases with the same spectrum of resistance among relatives of such patients or among healthcare workers who provide care to them?
So just before I forget what I want to say for the second part, I'll just start with the second part first. So Kid Data, I don't know if you saw a couple of days ago, presented a study that he had done, or him and his group had done, looking at patients who'd been discharged from hospitals, TB hospitals in Cape Town, and had then gone on to die, but had sort of stayed alive for an average of like nearly a year or something, so it's not people going home and dying immediately, it's people going out into the communities. And he had done a study showing that contacts of those patients had then contracted XDR TB from those patients. So, that's to be expected in very high density populations. But I think, that was a very small proportion of patients, and I think we focus a little bit too much on that. When you think of the broader picture of the infection control risks in our communities, are really those patients, who are coughing and who are actively moving around the community before they get diagnosed. So that's really where the transmission occurs, right before they get onto treatment. Often when people are discharged without any treatment, not to say that they're all bedbound, but a lot of them are not moving around. They've been through the system. They know themselves. They're not delinquent and wanting to go and spread TB within the community. They are taking as many precautions as they can to protect others from the disease that they have. So I think when we think of infection control and our risk, we should be thinking more of finding the TB and treating it, as opposed to ostracizing those patients who have been through the system and the treatment has actually failed. It's not them who failed, it's the treatment's failed them. We just don't have good enough treatment. And so just going to the first part of your question, what we focus on is educating the family as far as possible as to what they can do to protect themselves. So obviously they want to provide support to their family. Well, sometimes they don't, but most of the time they want to provide support, but they're also worried about themselves and their children. And I think what we've found is that once you start engaging the family on what the issues are, and not just telling them what to do, but starting to say, look, this is what's going to put you at more risk, or this is what's going to be a problem, they start making plans for themselves. So they make plans for that work for themselves that we could never have thought of. So for example, they'll say, oh, you know what, our kids are more at risk, or our grandmothers are more at risk. We're going to actually ask if they can move away from the home and go back to the Eastern Cape, go back to other areas, or go and live with family members while we have this patient at home with us. We're going to try and find the funding to build an extra room on the side of our house with windows that open, and once they know what infection control measures they could take and how DRTB is transmitted, then they make the plans for themselves. So I found that really powerful, just in our experience. In the time I've worked in Kailicha, which is 7 years, we've had lots of patients who've died, lots of XDR patients, and obviously, people can be infected with TB and develop it many years later, but in the time I've been there, I've not known anyone to be, any family members or close contacts, to have become sick with DRTB after looking after their XDR patients. So we have had some examples of XDR patients, like young men who've had treatment withdrawn, and they've just been the only breadwinners for their family, and so they've gone off and got a job driving a taxi. And so you hear about this XXXDR treatment failure patient driving a taxi, and that requires different levels of intervention. So that required going to the taxi owners, going to the taxi association, informing them that there is this problem. And actually it was amazing how supportive they were in making a plan, because they didn't know that the taxi driver had XDR-TB, making a plan to stop him driving, and actually supported his family knowing that he couldn't have an income. So I think this community engagement and education and information sharing is so much more important than saying, we have to put these patients into a building on top of a hill in the middle of wherever, So I think it requires a lot more effort, a lot more resources, a lot more motivation, which often a lot of programs just don't have the capacity for. Yeah.
Liga Kukša from Latvia. I actually would like to thank you for this session, and I just 1 hour before recognized that this session happened, and I'm happy to meet you, especially Stephen. And we have very large experience with palliative care in Latvia. But referring to your question about the infectiousness and infection control, actually after the stopping the curative treatment, as we say, those patients live quite a long 17, we calculated 17 months. MDR patients, a bit less those with XDR-TB, depending on clinical condition. It means after the stopping the specific treatment, they became extremely infectious. And that's very important from the two sides, that this is, first of all, ethical question to help our patients and with their symptoms, but also infection control perspective, that not transmit extremely, how to say, dangerous disease around the community. And also we have the epidemiological studies which shows that if without proper infection control, we produce more and more those XDR cases. But we had, in Latvia, we had 10 years, how to say, specific ward for those patients without curative treatment. And even though you never can say that your patient is palliative at the moment and still ever, because with coming with new tools, we are able to treat more and more. And it happens also in Latvia. We had more than 200 palliative cohort in the middle of 90s. And today we have 1 or 2 cases per year which need palliative care. I mean, not palliative care at all, but let's say end-of-life care. And I would like to stress that this is complex management of the cases from the very beginning, as you said, till the end of life if needed, but also to remember that case management, all those parts of case management is still essential, even with new medications coming in and new technologies coming in.
Thank you, Liga.
I just also want to say one more thing. I just remembered. One thing I really worry about is when we see, these patients at the end of life care, if we have to be careful how we manage them, because what we've seen, a couple of just anecdotal examples, is that, and this is not necessarily within households, we have big support groups that we run. For anybody, it can be for any DRTB patients, and often it's the patients who start on treatment, but we have older ones as well, and so people can see that, oh, there's some hope, I can finish my treatment, or they can see people who are suffering and they'll be like, I actually don't want to get to that stage either. But I think what we risk is if we say, oh gosh, you've got XXX-DRTB, it's untreatable, and we put you in hospital and we send you away and, get really scared of you, then it actually drives the epidemic underground. People aren't going to come forward then and say, gosh, I've got these symptoms of TB and I've got a contact who's got drug-resistant TB. They're just not going to come forward and get treatment. So I do think we have to be very careful about how we manage those people at the end of the line, yeah.
Got 10 more minutes.
Hi, I'm Erin Whitehouse. I'm a PhD student and nurse. I guess I just have an interesting question about, I'm not a palliative care expert at all, but it just seems like one of the challenges is language, because so many of these concepts should be integrated into care if you're caring for a patient holistically. So even with funding and with implementing, I don't know, I'm just curious about the challenges of defining something like end-of-life care so that you can focus on that, but also how to say, but palliative care, if we don't start from day one, then by the time that we don't know who's going to be successful, and everybody should have spiritual care, and everybody should, on some level, have some of these elements. So I don't know, I was just curious a little bit your thoughts on that.
Yeah, I started working over 40 years ago in palliative care, and we used to say to ourselves, in 20 years we'll be out of business. That we will just have integrated all these concepts in holistic care and such, and it's just good care. I mean, it's what we should be doing with maybe not everybody, because it could get expensive, but we failed. And it wasn't that we failed, it was that there is a need for specialized palliative care, as it turns out. That not everybody in healthcare can or will or wants to deal with the needs of people that eventually will die of their illness. I think what we haven't done is done enough to sort of really bring it into primary care. And we've got now a primary palliative care association. We have some serious efforts going in to try to integrate palliative care. Oncology, ASCO has called on oncologists to integrate palliative care from the beginning of treatment. I mean, there's a lot of signs. Maybe in 50 years it'll be less. And then there's the terminology issue. People keep saying, well, palliative care came about because Balfour Mount in French-speaking Canada couldn't use the word hospice because it meant poorhouse. and French, at least in French Canada. And so, hospice has become associated with death, palliative care to some extent also. And so people came up, well, let's call it supportive care. And it's sort of like, well, or is this just because we don't know how to deal with death as professionals? Or what's the problem? I think we have to do a better job of training everybody who works in healthcare and include the principals. And yeah, I think it's good care. Everybody should get that circle we were looking at, I think. But maybe if you have a broken arm or something, you just need to, get a cast. But
actually, just to pick up on this last point, I'm wondering if there's any data about palliative care and success of palliative care in indigenous communities. So the reason I ask that is I know that at least within the Canadian context, although it's a heterogeneous group, indigenous populations tend to have a much more holistic understanding of wellness and health. And palliative care, I would assume and this is a huge assumption, but I would assume would be sort of germane to that worldview. And so I'm wondering, do you know of any studies that look at that differentiation?
There's not been much. In Australia, Aboriginal people have, I think, first of all, as societies get more and more rich, there is more and more of a disconnect between, within the community. Families, multi-generational families, stop living together, people travel for work. All the things we know from modern life that, I'm trying to make a larger point, which is it's not just about indigenous people, it's about society and about how we deal with it. In fact, I hear all the time people saying, well, we don't talk about death in our country because our culture is against it. But it isn't a cultural issue because every country has this problem. And it's really more of a psychological issue, I think, that people won't talk about it and are afraid of what will happen if they talk openly about it, or they have their own death anxiety about it. Indigenous people, there just isn't much on it that I've seen published. In the US, we've had initiatives to have palliative care for people, American Indians, for instance, and Aleuts, people in the Aleutian Islands. But there's just very little on it, sadly.
Yeah, thanks so much. I really appreciate having this session. And one thing I wanted to comment on that you mentioned earlier, and I have a question as well, is sort of looking at palliative care and how its relationship to TB and whether or not that's unique. One thing that I've seen that's a challenge with TB is that, and this crosses over, I think, with ethics, is the issues around isolation and autonomy around choosing to take treatment or not. And I have seen recently some patients who have been hospitalized for a long time because they're considered potentially infectious and they don't have a setting. In the US, we won't have people go back to a home with young children or immunocompromised. And so, I think with other diseases, you can honestly say someone has a choice, and I think sometimes that's a little bit it's less straightforward with our TB patients, and I think staff, in the best of intentions, sometimes really, they don't present it as like an option to start. They really want to keep people on treatment out of a good intention, but I think sometimes that can create tension, and some patients to say, you know what, they sort of passively say, I'm okay with dying, I don't want to take these medications anymore. Sometimes older patients, we have a lot of older patients with TB and MDR-TB, and sometimes even younger patients. So I have thought that palliative care, from my experience with them, they have a lot of, I think, really great communication skills around talking about goals of therapy and maybe have less of an agenda, because I think in TB we have a little more of an agenda. So it's just one of my observations. I wonder what you think about that sort of issue around autonomy, choice, and this communication with TB patients, and maybe a role for palliative care professionals in those kind of discussions, if that makes sense.
Well, I mean, we've, from the very beginning, been supporters of autonomy and self-determination, and also agency. I mean, I think agency is a better way of thinking sometimes about this, that the person, we're not giving them autonomy, they have their own agency. I don't know if you might want to comment on this question, since you're one of our ethics experts in the room, but I think we do all we can to support patients making decisions that are consistent with their values and goals. And if they decide, in palliative care, I think we're more comfortable with people making those decisions than in other specialties within healthcare.
Yeah, so within the WHO document, within the literature, within the ethics and human rights literature, it's quite clear sort of consensus that you can't force treatment upon individuals. It's pretty unequivocal in the literature. So what happens in practice obviously differs quite a bit. What I think the issue with palliative care is terrific is that it sort of presents another option along with sort of the traditional means. I think that, I don't know if this is perhaps where you were going, but the idea within TB care is that it's also it serves a public health function, and therein lies the rub. However, I think what we ought to acknowledge, and we do an insufficient job, is again, at least in theory, there's a lot of infection control that can happen apart from taking the medications themselves, although perhaps more difficultly. But yeah, I guess from the ethics and human rights literature, it's pretty clear-cut in practice.
Okay. Yep. Jenny, do you want to make any final comments before we close the session? Okay.
We have the privilege to have Professor Leslie London, who is like an expert on human rights and ethics, and specifically in TB. He's got an interest in TB, and we have these in each province we have these committees that meet once a month to discuss patients who maybe the treatment is failing, or maybe they've decided they don't want their treatment anymore, but they're very emotional, sort of passionate discussions, and it basically has to have a human rights person there, and a lawyer, and a doctor, and all the different specialists, and the social workers, etc. And I kind of come away from those sessions feeling like we should get ethics points for like continuing professional development, because they're such intense discussions, and it's exactly these things. I just presented a patient who was desperate for treatment. We wanted to give him treatment, but I mean, we discussed these patients who, just said, look, I don't want my treatment, and they default, multiple times until it gets to the point they get XDR-TB, and then they decide, okay, now I want the treatment. But actually we're saying, well, from a medical perspective, there's no more treatment left for you, so we're not going to give you treatment. We're going to withhold treatment. So now you have to go home and be at home, and we're not going to give you any more treatment, and then what obligation do we have to provide palliative care services, which we're not providing, so it becomes this very difficult issue with those people who are saying, well, I have decided I don't want to take this treatment. So it becomes very tricky, and I think the ethical discussions can go on for ages, but it's a good job we have these discussions so that we're always aware of them, yeah.
Well, on that note, I want to thank you all very much for coming and sticking around, and some great questions, and if there's nothing else, we'll close the session. I guess we're reluctant to leave. I don't know. Thanks very much, really. Seriously. We'll stick around.